You're going.
Go.
Okay, so we have a client who's complaining about closing angle pinches in the deep squat position in the ankle as well as the hips. Bilaterally worse on the left, and the hips are bad on both sides. So I'll show you the squat in 1 second, but there's a history of significant weightlifting prior to coming in today, and then he had switched from weightlifting to gymnastics training how long ago?
4 months.
4 months ago. So the client is noting that now that he's gone away from a heavy amount of front squatting, it seems to feel better. Is that correct?
Yeah.
So now he's just doing his, regular body weight squats, staying within his prerequisites. Whereas previously, just from his history, I anticipated that if you have this anterior ankle mortise pinch and you have this anterior pinch in the hip capsules, that likely there was an ankle dorsiflexion prerequisite that wasn't being met, which means that his front squats were over compressing the anterior aspect of his hip. Now we come down to his ankle here, if you just bring the thing around. So if I keep that knee straight and I bring him up to his maximum ankle dorsiflexion, you see that we're only approximating 90 degrees here. Now if I add in his great toe movement, you see that we have restriction there as well. Other side, if I bring that ankle up, especially if I bring it up with the idea of keeping the knee in line with that second toe, I run into a great deal of resistance here. Same with that knee. Or sorry, same with that toe. So if we come up to his hips now, you're going to guess, of course, that we're going to get a closing angle pain on cars. So if I bring him in here and I start to do some passive cars, what do we got? What do you feel?
Hip impingement.
Where do you feel it?
Right at the front.
Okay, so we got a closing angle pinch. Based on the history, without looking at his internal rotation, you would assume that this client just suffers from not having hips. So if we go into internal rotation, what are we going to find? We're going to find an immediate resistance. It's not a hard block, which means that the prognosis is good, but you can see that any further motion, and we have a complete rising of that pelvis. So clearly, we have hips that are not suitable for anything past bodyweight squatting, and we have ankles that are not suitable for anything past either bodyweight or low bar back squatting. Okay, so you're going to bring him down in a squat here. Okay, so we see the amount of forward lean that he's using to balance himself. You can also see on the toes. You see how he's lifting his toes? If I just touched him back this way, he'd probably lose some balance here. So you see how the balance is really thrown off? Because he clearly can't put weight forward. Why can't you put weight forward? Well, if you don't have the ankles to, you can't. You'll also notice how he's kind of faking dorsiflexion. You see his knee is coming out over his toes. If I try to put his knee onto his big toe, you see that we can't do it, and we're not even achieving the knee at the toe level. Of course, for front squats, we're going to be way further ahead. So in this position, when you lack your dorsiflexion, you're going to have a more acute flexion angle. As you can see, he's reaching forward, and that's going to lead to that hip impingement or vice versa. So generally here, we're going to have to clear up his ankle dorsiflexion. Because there's a mortise impingement, we have to focus on the posterior capsule of the mortise joint to allow it to clear. You'll remember from seminars, I've always done this kind of example. If the back part if the undersurface of the capsule is tight, you're going to impinge on the contralateral side. So we're going to have to work there. We're also going to have to work the same in the hips as we generate him new hips.